From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center. Today, we are discussing non-traumatic intracerebral hemorrhage, specifically in regards to location and timing of recurrence. Joining me today is Dr. David Seiffge. Dr. Seiffge is a vascular neurologist and professor of neurology, as well as director of the stroke unit at Bern University Hospital in Bern, Switzerland. Dr. Seiffge, thank you so much for joining us today.
Thank you, Dr. Armand, for the kind invitation.
I really think that this topic is something that is extremely scary to individuals in the world of neurology. And I wanted to have a little bit of a background in terms of your experience with encountering intracerebral hemorrhage patients, in your observance of how they occur, common causes, as well as what really sparked your interest in this topic in terms of what we're discussing today.
Yeah, thank you. So intracerebral hemorrhage is a disease causing significant morbidity and mortality. It accounts for only 15% of all strokes, but those are the most deadliest ones. And a lot of those patients actually remain disabled even after 3 months and later on. So we see many of those patients our daily life on the stroke units. And one of the most feared complications of ICH is actually having recurrent ICH. So patients are at risk once they have a ICH of having a second ICH later on. The major cause of ICH in elderly, in more than 80% of the cases, are small vessel diseases. And there are two types. The first one is cerebral amyloid angiopathy, which is caused by amyloid deposit in leptomeningeal arteries. And the second one is hypertension-associated arteriolopathy, which also causes ICH. And the risk of recurrence is mainly dependent on the type of ICH. What we observe in clinical practice is that we, at the moment, focus mainly on risk factors in the management of recurrent ICH. We are counting risk factors like hypertension, like age, like hematoma location, but we really don't understand why actually those patients are bleeding. And our research topic started from an observation in clinical practice when we see patients who have had an ICH before, and then they are coming back with a second ICH, which is actually adjacent to the previous one, just in a brain area which is next to the other one. And our research was actually triggered by this observation.
Now, do we know specifically about the time frame of when a recurrence can occur? Because I know that there are surveillance guidelines with individuals like this. They come back to the clinic, they're having repeated imaging or following their neurologic exam. What do you usually do in practice?
So actually, the literature on this topic is quite scarce. So we know from literature that the annualized rate of recurrence in the first year after an ICH is somewhere between 1% and 7%. So a vague last spectrum. And we in our clinics, we actually invite patients to come back after 3 months and then after 12 months to see those patients for recurrence.
Right.
But actually, the exact timing of recurrent ICH after a first ICH was not well studied before our study.
I see. And then my next question before we dive into your study is, when I think about what you said in terms of the recurrence and where it happens, adjacent to the tissue in a remote area, what do you think about that? I would think that it obviously depends on the etiology, but also maybe something about the tissue that is healing and changes that are occurring that could be affecting the surroundings. I'm wondering what your thoughts are on that.
That was exactly the question that we also had. We are wondering, why do these patients actually bleed again, and why do these bleedings occur so close to a previous bleeding? What are the reasons behind? And this should be tissue-related factors, but Is it a local disease progression? Is it the local disease burden, so a higher burden, for example, of amyloid deposition or a later stage of amyloid angiopathy? Or is it a secondary factor like related inflammation, which actually causes the tissue to be prone for recurrent ICH in the same area? This was something that triggered our research.
Wonderful. So I'm happy to hear about this. So tell us about the setup of your study and primary, secondary outcomes you were looking into specifically.
Yeah, thank you. So based on the clinical observation that we saw patients who had an adjacent ICH, meaning closely related to a previous ICH in our clinical practice, we were asking ourselves in Bern, is this a frequent scenario? But to answer these kind of questions, you have to have a large consortium, a large sample size. So we contacted about 14 other cohort studies in Europe who actually had local prospective cohorts of ICH survivors, which were followed up in their respective centers for recurrent ICH, to combine these individual patient data on those patients who actually had a recurrent ICH. And our primary outcome was adjacent ICH, meaning an intracerebral hemorrhage occurring next to a previous ICH in terms of anatomical location and side of the brain, in contrast to a remote ICH, meaning recurrent bleeding, which was on a different area of the brain. And the secondary outcome was time from the first bleeding to the second bleeding.
What kind of confounders do you adjust for in this setup?
So we collected data on hematoma location, of course, on several hematoma characteristics like extension of the subarachnoid space, but also presence of cerebral amyloid angiopathy and hypertension, but also treatment of hypertension as confounders.
Right. Now, tell us about your results.
So the results of our study were that among 14 cohorts comprising 20 centers enrolling more than 30,000 patients with an intracerebral hemorrhage, 433 patients actually had a recurrent ICH. And among those, virtually every second patient, 46%, had an adjacent ICH close to the index bleeding, and 53% had a remote ICH in a different area of the brain. In terms of timing, those patients who had an adjacent ICH had their event earlier, with a median time between the first ICH and the second one of 1.2 years, compared to those with a remote ICH, where the timing between the first and second ICH was 2.2 years. Overall, having an adjacent ICH was associated with imaging markers and a formal diagnosis of cerebral amyloid angiopathy, while timing, having a recurrent ICH earlier, was associated with a previous lobar or convexity subarachnoid hemorrhage.
So it looks like the cerebral amyloid angiopathy is in fact a risk factor for early rebleeding as well as adjacent rebleeding in those areas.
Yeah, that's true. That's one of the major findings of our study, I think, that those patients who have a cerebral amyloid angiopathy, we already knew about that those patients are at highest risk of having a recurrent bleeding. But now that we also identified that those patients tend to bleed in an area close to a previous bleeding, actually acts to the importance of tissue-specific factors. There are actually other studies which have been published recently identifying also that cerebral amyloid angiopathy actually seems to spread locally with imaging markers which are frequently asymptomatic, which include lobar microbleeds or cortical superficial siderosis, tend also to spread locally, which actually adds to our understanding of the disease.
Right. So that's really important. I mean, in these imaging studies that we see of these patients, you do definitely see the evidence of the microbleeds, and sometimes they're diffuse, so you can really hone in on different areas. Do you know specifically what certain markers are highly involved in terms of contributing to that, the rebleeding and vulnerability of that tissue?
So the major imaging marker in cerebral angiopathy is actually convexity subarachnoid hemorrhage or cortical superficial siderosis,
Right.
which tends to extend over time, and it's now also included in the novel Boston 2.0 criteria to diagnose cerebral amyloid angiopathy, having now this multifocal cortical superficial siderosis as one of the main criteria is actually a big advantage and helps us for the understanding of the disease.
Now, how do you think this begins to change what we do clinically and how we approach these patients?
I think our study opens the door to a totally novel way of looking at intracerebral hemorrhage and its recurrence. Before, we were only counting risk factors and treating risk factors, but actually,
Hmm.
the hypertension or the anticoagulant doesn't bleed. It's the tissue that bleeds.
Right.
And the findings of our study skip the focus from risk factors to tissue factors. And actually, it points us towards that we need to better understand what actually happens in the tissue, what happens in the brain of those patients, what makes them prone to bleed, and how can we actually interfere with this bleeding risk, and how can we prevent this recurrent bleeding. At the end, I think the idea of our study was to identify a factor which may one day be treatable.
Right. Exactly. Are you kind of cooking this up in your research lab currently, dare I say?
Definitely. I think it's the way that we're going to pursue. Now that we have identified these early adjacent rebleedings as a very specific subgroup of recurrent ICH, we need to better understand what's actually happening in those patients. We need to understand what type of tissue factors drive the recurrence. Is it local tissue burden, disease burden? Is it local disease progression? Is it neuroinflammation? We see that there is an entire spectrum of cerebral amyloid angiopathy related inflammation that we're now discovering that inflammation in cerebral amyloid angiopathy
Hmm.
might play a role in different terms of severity, and whether this is also a cause that drives early recurrent adjacent rebleeding is unknown at the moment, but it is something that we are definitely pursuing because this would be in return a very interesting treatment target.
Right, exactly. I think the findings of your study are remarkable and definitely benefit patients in the long run. And I'm certainly looking forward to next steps in your research process and new developments. Now, are there any other important factors from your research results that you wanted to discuss with us and make sure our listeners hone in on?
Yeah, thank you for this question. I think we are living in a very exciting time. So we are living in a time with a new dawn of treatment opportunities in intracerebral hemorrhage. We have seen also minimal invasive surgery for hematoma
Hmm.
evacuation now being proven as an effective treatment in randomized controlled trial, which actually opens and really fits well with our research because now
Hmm.
more patients will actually benefit from minimal invasive surgery, which on the other terms opens us the access to brain tissue and to actually study what's happening. And if you go further, if once in a few years we have identified factors that contribute to early recurrent bleedings and those are actually treatable, you can even imagine that we might combine a hematoma evacuation with immediately treating the tissue of the patient locally with what is needed to prevent recurrent ICH, whether this is an anti-amyloid drug to prevent disease progression or an anti-inflammatory drug to prevent neuroinflammation. I don't know because we don't have these results yet. But in theory, you can think about the future combining those treatment options, which is, I think, a good prospect for the future.
Right. In my mind, I'm thinking of targeting specific inflammatory markers or proteins that can actually lead to that decrease in recurrence. I think that's remarkable.
That's exactly what we are also thinking about. It's like in other brain diseases where for a tumor, when you operate on the tumor, you resect the tumor, and you can think about having a local chemotherapy installed in the brain at the same moment. I think this is something we should consider for these types of bleeds in the future. This is something which might come up one day if we actually identify those factors and they are treatable, of course.
This is wonderful, Dr. Seiffge. Thank you so much for joining us today and enlightening our listeners on this topic and clearing a path forward for treating intracerebral hemorrhage and facing potential recurrence.
Thank you very much, Dr. Armand, for having me, and it was a pleasure. And I would like to thank all the collaborators on this project which contributed data and who it was really a wonderful collaboration. I would just highlight one person, Martina Göldlin, my PhD candidate, who actually was the motor behind this and the success of this collaboration.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. David Seiffge about recurrent intracerebral hemorrhage. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.